Chairman, ladies and gentlemen, first of all, I'd like to take the opportunity for thanking Mohammed and his colleagues for inviting me here again. This is a tremendous meeting. I learned so much from it when I come in terms of the discussions and the academic discussion. So, talking about hepatic encephalopathy, I think the first thing to say, and I'll try and cover both aspects of this, is that encephalopathy in cirrhosis or acute on chronics is a very different beast to that in acute liver failure, and we must recognize that. In acute liver failure, you see a presentation where you are at risk of cerebral edema, brain swelling, you have hyperreflexia and clonus, rapid deterioration. You either recover with normal brain function, you might need transplantation. At that point, we need both the brain and the liver to recover, otherwise it's a disaster, or you may not recover. In the cirrhotic population, brain swelling, clinically important brain swelling, is rare, and we'll talk about that something on the subsequent slides. There are often Parkinsonian features. Small vessel disease might also be seen and has to be considered in the differential diagnosis. And the chronic brain injury, the dementias and the deliriums also need to be considered. The etiological factors in terms of both encephalopathy and cerebral edema are represented on this slide. And there isn't time in this presentation to go through all of the areas, though particularly the important factors are probably cerebral hyperemia, abnormal astrocyte metabolism related to glutamine, ammonia, mitochondrial toxicity, the vascular function and the vasomotor function. Those are the important salient facts. In terms of precipitants, for acute liver failure, the important issues are that you get a sudden loss of liver metabolic hepatocyte capacity with necrosis and apoptosis. And what is very clear then is the role of inflammation as well as a secondary hit phenomena. It's fascinating in paracetamol-induced acute liver failure that patients develop a profound coagulopathy which peaks at 72 hours. At that time, the majority of them are still sitting talking to you. Their encephalopathy peaks at day 5. Their portal hypertension develops at day 10 to 14. It's a really interesting time course. By contrast, as we're all aware, in acute on chronic liver failure, the precipitants of infection, variceal bleeding, metabolic insults, and alcohol are the common causes. In terms of how we define encephalopathy, as hepatologists, this will be well known to you. It comes from a relatively recent review from the EASL guidelines of the overt and covert levels of encephalopathy in cirrhotics. I think it's important to emphasize that grade 3 coma is very different in a cirrhotic to an acute liver failure. Most cirrhotics just become more and more unconscious, having gone through that loss of night-day orientation. By contrast, an acute liver failure becomes profoundly aggressive and difficult to manage. And in that, they are very different. For those of us who practice a lot of intensive care, rather than using the standard grade 1 to grade 4, we are also inclined to use Glasgow Coma scale. They actually correlate quite well, grade 3-4 being really a GCS below 9, but it is useful to utilize both when you're describing patients. I think this data is really interesting and worth considering, published a couple of years ago by Jan Cordoba, showing very clearly the characteristics of patients with encephalopathy. Perhaps the most important thing is the cumulative mortality that you see in the top right-hand side of this slide, that having got grade 3-4 coma, your chances of surviving is really going down quite rapidly in terms of your subsequent decision-making. And what's also then important is whether you're encephalopathic as just a decompensated cirrhotic, or with that superimposed inflammatory phenotype of acute on chronic liver failure, which you also see on the lower graph to the right, such that acute on chronic liver failure plus encephalopathy, again, the highest mortality, versus just encephalopathy without acute on chronic with a much lower outcome. This review by my colleague Rajiv Jalan, published earlier last year in the Journal of Hepatology, nicely pulls together the pathophysiology that we should be considering. That close interaction between brain function, liver function, gut function, muscle metabolism of glutamine and ammonia, and importantly also the kidney. So all of these organs that we've been talking about earlier this afternoon come together. And it's important to recognize that the kidney excretes ammonia. So when you've got that small deterioration in renal function, you won't clear ammonia and you will see more development of encephalopathy. So again, I would emphasize that that close attention to detail is really important. Similarly, to the right of this slide, the emphasis of ammonia, inflammation through cytokines, hyponatremia, which we'll talk about some more, and glycemic control. I draw your attention on this slide particularly to the brain glutamine in the far right of this slide, where you see the changes between someone with encephalopathy and with reversion of encephalopathy with the falling brain glutamine. Again, emphasizing the importance of ammonia and glutamine in the brain in development of encephalopathy. And also this in terms of ammonia. We forget in terms of pH the importance of separation of ammonium and ammonia. And again, to the bottom right of this slide, I would emphasize that close relationship between brain uptake of ammonia, cerebral blood flow, and arterial pH. These are closely interacting, and it's important in our day-to-day practice. The other thing to remember is when you're measuring ammonia is where you're measuring it from. Arterial ammonia is the gold standard. It's important that if you're taking a femoral venous or a right atrial ammonia, that you recognize that's going to be lower. And that's emphasized nicely on both of these slides. Again, the right-hand slide shows the relationship between femoral venous ammonia and arterial ammonia. And there's a 35 to 45% drop across your quadriceps, recognizing that your muscle bulk has important ammonia detoxifying capacity. And I'm sure in terms of going further in drug therapy and training of osteotic patients, this is what we should be focusing on. Inflammation is nicely demonstrated here. It's an old study, but I think it shows the message very clearly. You show here the TNF levels as we go from grade 0 to grade 4 encephalopathy, and then the resolution, again, of grade 3 encephalopathy down to grade 1. That close relationship between inflammation and decreased consciousness. Also seen very elegantly in these animal studies, this is work from Butterworth, showing again the importance in terms of brain as opposed to peripheral circulation. You see in the bottom of this panel elevated levels of IL-1 and TNF in the brains of animals in coma with hyperammonemia. And we must again come back to the effects of ammonia. Ammonia impairs your ability to phagocytose and resolve infection. So as ammonia goes above 50, you start seeing that decrease in neutrophil phagocytosis, an increased risk of infection, and hence again, this risk of inflammatory cascade. So again, there is something to be said for modulating ammonia downwards, not just in terms of overt encephalopathy, but also in terms of disease modulation. And this is also seen from other work from Debbie Shawcross, showing in cirrhotics with deep encephalopathy that the outcome is not related to ammonia level per se, but to evidence of inflammation. So again, I come back to this close relationship between the liver, the kidney, the guts, and the brain. remembering that in terms of ammonia clearance, the relationship, as you see on the right-hand panels of this slide, that as you ultrafiltrate on a filter, or you could be your kidney, there is a clear relationship between ammonia clearance and ultrafiltration rate, or indeed urea clearance. So early institution of renal replacement therapy will help resolve hyperammonemia and possibly modulate encephalopathy. We've talked about hyponatremia, and this is pivotal in the management also of encephalopathy. This data looking at transplant patients and hyponatremia on the waiting list, showing a clear relationship between both low and high levels of sodium in terms of morbidity and mortality. But also, I very much like this paper published a few years ago now, showing clearly that if you've had hyponatremia, even if it's then resolved, you see a marked increased incidence of delirium, renal failure, and pneumonia and rejection in the post-transplant course. So that relationship again of sodium and outcome is clearly important. And again seen from the acute on chronic liver failure canionic study, that clear relationship between hyponatremia and outcome. In terms of nutrition, we sometimes think that we should deprive our patients of food or limit their protein load when they're encephalopathic. And this data, which is quite old now, and I think Jan Cordoba is to be commended for the excellence of this study, enrolling people with deep levels of encephalopathy and getting them fed either a low protein diet or a normal protein diet. There is no difference in terms of incidence of encephalopathy resolution in these two groups, but importantly, those with the normal protein diet, as can be seen on that bottom panel to the right, clearly show a better balance between protein synthesis and breakdown at day 2, although by day 14, the two groups are very similar. So probably early, normal enteral nutrition. Can albumin help in terms of encephalopathy? Its putative role in inflammation, we believe it to be a magical fluid. Well, maybe not. Certainly this data again from the Spanish groups published a few years ago now showed that resolution of encephalopathy in those treated with albumin versus control fluid was not significantly different. However, the long-term mortality did show a benefit. So I guess the jury is out in regard of that. Other treatments, as well as lactulose, that might be considered with good effectiveness, polyethylene glycol, highly effective, published a few years ago. And of course, albumin dialysis also results in improved resolution of encephalopathy in this cohort, but there isn't a mortality benefit. I'm aware time is against me, so my apologies that I'm flipping through these quite quickly. This is some data from Joshi Deepak, a colleague of mine back at King's, where they looked at patients with acute on chronic liver failure undergoing CT scanning, looking for evidence of cerebral edema in this cirrhotic population, separating them into acute on chronic liver failure and decompensated cirrhotics. They were well matched. And perhaps what's important to note is that, in fact, the incidence of cerebral edema was very low, only 3 patients of this total cohort. But equally, there was a large incidence of small vessel disease and also a significant incidence of intracerebral hemorrhage, very different from an acute liver failure population. Those patients who did get cerebral edema were those who had previously been Child-Pugh, had had a sudden drop in sodium and a sudden change in ammonia. So you can probably identify those cirrhotics that are at risk of cerebral edema. So what are the neurological issues which might cause us concern in the peri-transplant and post-transplant period? Well, certainly ongoing encephalopathy, perhaps related to graft function, delirium, seizures, Press syndrome should always be considered. It is an underdiagnosed syndrome. Pre-existing small vessel disease and intracerebral events. And something we sometimes forget is the toxicity of the drugs that we give to the brain, particularly in terms of some of the antivirals and the tacrolimus agents, as well as antibiotics. I just want to talk for a few moments in the last few minutes of this presentation about acute liver failure. It is a very different disease. This slide is well known to those of you who know me well because I always use it, because it was my error that resulted in this slide. I was on a ward round. I ignored the nurses who said that the patient in bed 2 is getting a bit antsy, which is a London statement for they're getting agitated. I wanted to finish my ward round. By the time I got back, this was the remnants of the ECG and the arterial line, which had been chewed through by the patient who was trying to rapidly escape the ITU. We had to administer drugs standing on the bed with the patient. It was not fun, and I don't suggest that anyone does it while transferring a patient. So if you've got an acute liver failure who's getting irritable, you assume that this is encephalopathy, that it's possibly rapidly progressive, and that you should sedate them carefully and look after their airway prior to transfer to a specialist unit. Your risk of getting a tight brain, cerebral edema, and acute liver failure is clearly related to grade 3-4 coma, the age of the patient, their hemodynamic stability or otherwise, their sodium, their ammonia level, and the presence or absence of renal failure. And what's perhaps most important is that potential response of ammonia to treatment. So if your ammonia drops with treatment, your risk of getting cerebral edema is vastly decreased compared to a patient whose ammonia levels remain elevated despite treatment. Have I got a few minutes grace, Professor R? So whatever's happening, acute cerebral edema in acute liver failure is decreasing, as you see here. The evidence over time is that the percentage incidence of intracranial hypertension is going down, and that isn't just due to our transplantation colleagues. As you see in the bottom right, this is seen in those not proceeding to transplant also. It is seen whether you are less or greater than 25, and it is seen whether it is a paracetamol or a non-paracetamol induced etiology. The age thing is great fun because nothing is new in this world. Clearly, the younger you are, the greater your risk of cerebral edema. We reported that some years ago, but it was originally reported by Ware et al. Back in 1971. Always important to check PubMed. Renal function and sodium we've talked about. It's really important to keep the sodium up. And in terms of temperature, this was a slide of Professor Andy Bly's, who I remember very fondly. Hypothermia, should we be going there? All of the animal data suggests it's beneficial. Some clinical case series suggested it's beneficial. A small randomized controlled trial recently published does not show benefit either in terms of intracranial hypertension or indeed in terms of outcome. So avoidance of fever, clearly the case. Hypothermia, the jury remains out. So in terms of final comments, the reality is it's small increments that result in improved outcome. No special big flashbang wallop, teams and functionality. Thank you for your attention.